अस्सलाम वालेकुम फरीद साहब, आप ना को होस्ट हैं। अब आपको आवाज आ रही है मेरी?
जी मैडम, आवाज़ आपकी क्लियर है। मैडम आपको आवाज़ आ रही है मेरी?
हेलो।
जी जी मैडम, आपको आवाज़ आ रही है मेरी? हेलो। हेलो। जी मैडम, आपको आवाज़ आ रही है?
हेलो।
जी जी मैडम।
जी जी, मुझे
साउंड।
हाँ जी, मुझे आवाज आ रही है बिल्कुल। असल में हम लोग उसी में फंस गए हैं, पार्किंग की वजह से। तो बल्कि बाहर से लगा कर आए हैं। राउंड शुरू हो गया है ऊपर
नहीं
आपका?
मैडम, राउंड पूरे 11 बजे आएगा, शुरू होगा। अभी तो रिहर्सल आप कह लें आपके साथ हो रही है।
ठीक है। नहीं नहीं, जो है उनका जो गेस्ट है उनका
अभी
राउंड
तक
शुरू हो
गैस नहीं है।
गया। अच्छा, गेस्ट नहीं आया, चलें ठीक हो गया। तो फिर मेरा ख्याल है कि इंशाल्लाह डायरेक्टली ऊपर से शुरू करेंगे।
इंशाल्लाह। जी मैडम।
जी बस भाई, बिल्कुल लॉगिन बिल्कुल है क्लियर। तो मैं जो है ना, आपको मैंने को होस्ट बना दिया हुआ है। तो
ठीक
दरम्यान
है।
में तो अपने नेट की इंटरप्शन हुई तो फिर वो हो जाएगा। बाकी यूट्यूब पे भी सारा स्ट्रीम हो गया हुआ है, इसका स्टार्ट है, अल्लाह का शुक्र है। बाकी तो
ठीक
यही
है।
मुझे था। मतलब बहुत शुक्रिया प्रीता, बस
वेलकम।
आपको नेट ही रहे।
ठीक हो गया मैडम।
बहुत शुक्रिया, थैंक यू सो मच।
वेलकम।
Hello, I'm broadcasting live from Pins. So the broadcast will start in about 17 minutes from now. Stay tuned and looking forward to welcoming you all. So please don't leave the room because the webcast will start in about 17 minutes from now. Thank you very much. Stay tuned. We're gonna start in about 15 minutes from now. That get an opportunity of have of anything like that. I will keep updating. Uh, Thank you. Just stay here for 3 minutes. going to podcast live in about 2 minutes. It will be starting in a couple of minutes. Just try to stay tuned and just keep on joining in. And if you need anything, you can just WhatsApp me. Thank you. Hello, everybody. We are in the auditorium and we'll be starting in about a couple of minutes. But everyone is starting to pack up, so just try to stay tuned and have a blast in just a moment. As I told you, it's my alma mater from where I have myself completed my postgraduate training in neurosurgery. So it's a place I'm really pleased and honored to broadcast today with you all, and I hope you will all like it. And if you need any sort of guidance, further information, please feel free to message me, either directly inbox me, or you can send me a WhatsApp message. Thank you. Just stay tuned.
if I could achieve tumor-free margins. And being able to do that would allow you to improve the survival, but still not cure the tumor. Recently, about 3 years ago, the MD Anderson folks published another version of this concept with the idea of perilesional resection of tumor. And I very much endorse this idea because I think it is clearly the safest way to aggressively remove tumor. That is to exercise my whole principle. That is to remove the whole tumor. And the concept behind this is actually to stay at the interface between what is tumor and what is the normal brain, and actually to stay around in the normal brain whenever possible. Now, this study did not demonstrate an overall survival advantage, but the important thing was that it did demonstrate a better outcome. That is, their overall performance was better because fewer complications arose if you stayed away from those vessels in the sulci that were all that can be damaged when you do your resection within the tumor. So wherever possible, I strongly advocate this approach. And why? Because what is our mission? It is to make our patients better, to allow them a better quality of life. So this is one of those few patients that you have that started out young with their malignant glioma at the age of 42, but lived to be 54. And in that time, he skied until he was a year before his death. And he was able to be with his children and to raise his children for those 12 years that he was able to live. Even more important is this picture. It was sent to me about 4 years ago. It was sent to me by this young man right here. So it was sent to me by this young man who at that time had the resection of a posterior fossa ependymoma. He found this picture when he was going through a box of photographs that his parents had, and he decided to send it to me 35 years later. And that's a wonderful feeling for all neurosurgeons to be able to have the opportunity to have a reminder of what it means to have done a successful surgery. However, with respect to glioblastoma, very little progress has been made over the entire 40 years that I have been involved in neurosurgery one way or the other. And the reasons for this are all common. We know that the tumor is infiltrative, and we know that that limits the extent of any surgical resection. We know that the blood-brain barrier plays a role in limiting the kinds of chemotherapeutic and biological strategies that we have. We know, and this is a very important concept, about the genomic instability, the tumor heterogeneity. It is remarkable how much clonal proliferation occurs as the tumor progresses. And if you add a mutagenic treatment like radiation therapy and temozolomide, you further increase this mutagenic process. And the type of clonal proliferation makes it very difficult to target every single tumor cell with whatever therapy you have in mind. And so this is an example. This is an example of where as the tumor treatment progresses, you increasingly select the most resistant clones, and that invariably results in the failure of your treatment. So these are the kinds of clinical trials that have been going on over the course of the last several years, and they are all clinical trials that have been innovative in their design, but that have failed to show any real significant impact in the actual outcomes from patients. So just a few of these is, these are all of the various mutations and pathways that might be active in causing or a tumor developing. And we can develop various inhibitors for these pathways, but none of them yet has resulted in actually a tumor control. We have some success, an example being a BRAF inhibitor, and this can be seen in certain selected tumors, but they're very selected, they're very unique tumors. Likewise, with anti-PDF immunotherapy, you can sometimes see a response. But again, the problem is that these trials have never been generalized to the typical glioma. So we have not yet seen any type of innovative treatment that actually changes the outcomes that have remained remarkably stable over the last generation. So yeah, let's just move on. Let's just keep going. These are all just examples of recurrent treatments. And one example was the polio virus. And there were some initial publications that suggested this would be really wonderful. But once again, if you look at those curves, I would not be impressed. I would not think that that's going to represent a real solution to the problem of the malignant glioma. This is just a list, and it's a partial list of all of the trials that have been done in immunotherapy, none of which have shown any benefit that can be generalized to the entire population of patients with glioblastoma. So what does the future hold? How are we going to start making progress? The approach that I have been exposed to is with gene therapy. And the idea is that gene therapy has been around a long time. This is a Time article from 1999, just describing this promise of gene therapy. And what we're doing now is beginning the process of using gene therapy, but we're far away yet from being able to use it in a brain tumor. Right now, the gene therapy is being used for simple monogenetic mutations. And these are the various categories that we see that we can use. One is for gene replacement when there's been a loss of function. And I'll give an example of Tay-Sachs disease. One is gene silencing when there's been a gain of function, as in Huntington's disease. One is gene editing, which is becoming that's the Casper, Cas9 Casper therapy. And the last is adding additional genes to supplement and possibly alter the natural behavior, in this case, of a tumor. At our institution at the University of Massachusetts, we actually have a lot of protocols that are active. Some of them are related to lung disease, and some of them are related to neurodegenerative diseases. Basically, this is just a review of the gene of the natural process. If this is a Huntington's disease gene, and this is the area of the mutation, which is codes for CAG repeat, which means glutamine. The gene is transcribed. you end up with this mutated portion on the messenger RNA that enters into the cytosol, where it's going to be translated into the mutated protein, which then accumulates and becomes toxic in the cell. So if you wanted to do something about this, there are a number of possibilities we now have available for these specific point mutations. One of them that's the newest is the CRISPR-Cas9, but we also use antisense oligonucleotides. And out in the area of translation, we have microRNAs, which we use in Huntington's disease, and siRNA, which we also use in Huntington's disease. And all of these are meant to eliminate the translation of the mutated protein. Another strategy that has been developed in this laboratory group is something called siRNA. And this is where you have a synthetic RNA that the property that it has that has been most exciting to us is that it diffuses easily into the brain from the CSF. And this is a property that we don't have available to us with using the other delivery system, which is a virus called adeno-associated virus. So we think that this has the potential to be very useful. These are the ways in which we deliver CNS gene therapy. The first is by direct injection. And you could imagine that this could also be in the tumor. The second is by putting it into the spine, into the ventricle, and let it diffuse out into the brain. And the third is to give it intravenously with the proper trophism so that the vehicle, the adeno-associated virus, traffics predominantly into the brain. Another way to imagine this is if you had a target, and if this case was a tumor, and you had a treatment for the tumor, we would propose that you should actually use the neurons in this case, and the neurons then secrete whatever agent it is that will be tumoricidal or will suppress the tumor, and that diffuses out into the tumor itself. And that ultimately leads to the disappearance of the tumor. And this is a strategy that we imagine using at some time in the future. Another approach that I mentioned earlier was intravenous administration. We think that this probably has great potential as we improve the adeno-associated virus capsid. This is just to review the two ways in which gene therapy can be used. One is ex vivo. That is where you take the cells from the patient, you put them into the laboratory, you then transfect the cells and take whatever gene you wanted to add to that cell. You do it in the laboratory, and after that is completed, you inject it back into the patient. This is a strategy that is fundamentally used for something called CAR T therapy for cancer. It's something that's used for beta thalassemia now, which is an approved study. And the second way, which we're using in brain tumors, or imagine using, and we certainly are using it now in the gene therapy area, is by putting the gene into the adeno-associated virus and then injecting it back into the patient, either directly into the brain, into the CSF, or into the bloodstream. So this is the package that we're talking about, which is the adeno-associated virus. It's the capsid around it. And what you basically do is you take whatever gene you want to use and you insert it into the plasmid of the virus, and then you produce this virus in sufficient numbers to return to the patient. Just another example of the virus, the genome of the virus, replacing its genome with your transgene, whatever it is that you want to use, and then putting it back in to the patient. Just one example in Canavan's disease. This is one that we're using now in a clinical trial. I don't have the results of it because it's being done at the Massachusetts General Hospital. It was designed at the University of Massachusetts, but the clinical trial is being run elsewhere. And it's all about being able to correct for the absence of this enzyme, the aspartyl-acylase enzyme, which is part of the energetic mechanism of the cell. And the absence of that enzyme results in Canavan's disease, which then causes the eventual death of the patient. We've been working with adeno-associated virus for a long time. We won't go through this because of the time. The study that I have been most involved in is with Tay-Sachs. Tay-Sachs is a recessive mutation that results in the loss of a specific enzyme, hexagonase A, and if that's lost, and it occurs infantile, the child will die within 3 to 5 years. There is also a juvenile form in which death usually occurs in the second decade of life. It's how you process the gangliosides of the plasma membrane. And when you have an absence of that enzyme, the breakdown products in the lysosome accumulate because they can't be processed. The absence of the enzyme prevents the processing of that, and that results in the accumulation of all of these breakdown products, which ultimately become toxic. The actual therapy that we have is to inject the gene into the brain, in this case into the thalamus bilaterally, and also to infuse it through a catheter from the lumbar spine. The catheter is threaded all the way up to the cisterna magna, where the same preparation is given into the CSF. The strategy is that you plan the bithalamic injections preoperatively, and then you plan the operation itself. The patient is a 9-month-old child right there, and utilizing a robotic arm for placing the catheters. This is with the bilateral catheters implanted. This system is used because the infusion is done over several hours, so we don't keep, these are flexible convection enhanced delivery catheters that are used. These, you can see the target gets hit. This is after the injection of the AAV into the thalamus bilaterally. This is the CSF infusion. And we've published the initial series in Nature Medicine on the use of this strategy for patients. The problem, of course, is the many witches. If we're going to use gene therapy for the examples that I've given, Canavan's disease, Huntington's disease, Tay-Sachs, which genes and proteins are we going to target? Which direction of effect do we want to achieve? Which network or biological pathway are we going to engage? Which cell-specific pathway do we target? Which comorbidity do we consider? Which sex, race, or specific effects do we have to be concerned about? So that's just a list of the issues that we confront when we talk about gene therapy. So the inquiring mind is about innovation. And I believe that there will eventually be a gene therapy that will be effective in suppressing brain tumor from its very formation. That answer is going to be somewhere in this, somewhere within the genome, within the proteome, or within the metabolome. And we have experience in all of these areas. For example, the Canavan's disease is a metabolic disorder, and the Huntington's disease is a genomic disorder, as is the Tay-Sachs. But we're gaining experience, and somewhere within there, it's not going to be me that will figure that out, but maybe one of you will figure that out, and we'll know what is going to be the target that we will discover, that we can use the tools that we are now developing. Well, we're developing these tools because they're easy in a sense. When you're dealing with monogenetic disorders, we can target those effectively. When we're dealing with something like a glioma, we're going to have to be far smarter. It's going to take more effort, but it's out there, and you'll be able to achieve it someday. I believe that the answer is going to exist up here in determining what are the precursor cells. I'm not sure they're stem cells, but what are the precursor cells? And if we can know what those precursor cells are going to look like, we can almost certainly figure out what is the combination of effects that we want to manipulate to prevent them from ever transforming into a tumor cell. These are various other things that I think are of interest. I think metabolic pathways are exploitable because they're usually 2 or 3 step pathways. We have to find out what is unique to the tumor metabolism that is not shared by normal cell metabolism. And there are some interesting things that we have that we will possibly be able to do. I'm just giving some publications that are all recent within the last year of people working on some of these concepts at a very experimental level. None of this is anywhere near a clinical trial. This was one of the most interesting articles that just came out 3 months ago. This idea that you could use CRISPR-Cas9 to actually shred the genome of tumor cells. And what's remarkable is that when you investigate the clonal proliferation of the glioma, a lot of non-coding RNA segments are generated, which actually become repeat sequences, which are the target of the CRISPR-Cas9 system. And so it may indeed be possible when there's all of these non-coding RNA that are these repeat sequence that you may very well be able to literally destroy the tumor cells when they do arise. So the thing to just point out, though, is there are some potential dangers as well. These are some off-target effects. This is a death that was reported. It's not related to the particular issue of the gene therapy, but it was that the vector, the adeno-associated virus in this particular patient, generated a native immune response that resulted in acute respiratory distress syndrome that was lethal. These are rare events, but they shock the scientific community as well as the government when it does occur. There are other concerns that we have, and this is from a series of monkeys that I did, that the injection sites where we place the adeno-associated virus sometimes have persistent signal abnormalities, suggesting that we are damaging the very target that we're injecting into. In this case, the monkeys didn't have any ill effects from it, but we wonder whether there are some sustained ill effects that could occur. So The point here is that we have to be cautious as we move forward with this. There are potential dangers. This is a quote from Guanping Gao. Guanping is the director of our Gene Therapy Center. He's the smartest and most humble man that I know. And he said, I worry. I worry that we may take a step too far and create problems. And one of the limitations we have and why we're working on this is that everything I said about the injection of the gene using the adeno-associated virus, which enters into the nucleus, it does not enter into the DNA, but it enters into the nucleus, and it's epigenetically expressed. We have no way of the current treatments that we're doing of actually controlling that. We have no way to turn it off if it has an untoward effect. So we worry about that as well. But overall, it's been a delightful journey for me. This is some of our lab group. That's Guanping Gao and the center. And all of the lab people, postdocs and graduate students that work on these projects. And we're just part of a much larger team of multiple labs that are doing various aspects of this. There's a CRISPR-Cas9 lab, there's a siRNA lab, there's a nucleotide chemistry group. So this is an effort of lots of people to make this work go forward. So thank you all.
सर प्रेजेंटेशन सर खत्म हो गया, आपने इंट्रोडक्शन देना है सर।
Professor Gelka Library Manager as Astroship, Executive Director, please.
Thank you. So it gives me great pleasure to do the introduction for a dear friend in Rosso. I was thinking, when was the first time I met here? And I think when we were residents, I think she's probably the most recognized, most looked at female neurosurgeon I can think of, at least in North America. That when at least we were in residence, late 90s, early 90s. Gail has been such a popular person amongst the youngsters. Before I do that, I want to I'll talk about Gail in detail, but we want to welcome all our honored guests, starting with senior most Professor Naziz Saab, Professor Tariq Sulaiman Saab, Professor Khalid Khan, our previous outgoing executive director, Amin Suri Saab, Mohsen Saab is our current chief of neurology, Akram Saab recently retired, Qasim, in neurology, as well as our vascular section, and all our radiology partnerships, second care, and Richard Moser, who we already listened to a wonderful thought-provoking genomics talk, and his lovely wife, Piari. In fact, it's called Piari. Piari means lovely. And when I met her the first time in 2019, she said, I said, you know what Piari means? And I still was recalling that. And of course, Professor Nabil Ashraf Saab, I kept him at the end because him and Shazad, Professor Shazad, and Mohammed. This is a trio I would like to mention because I think they have been instrumental in getting them. Well, they were coming to Peshawar for a global meeting anyways. But then getting them to Lahore, even though I've talked to Gail so many times about coming to Lahore, but I think they managed to bring them and ride with them and arrange for the stay, and there'll be wonderful course also. Of course, the others are wonderful MS and Professor Nurses this evening, and all our young faculty, nurses, residents, students, medical students, I think they're in the classes. But now switching back to Gail. I think her introduction would take 30 minutes. That's the total. But the single point which I don't know how much you realize, but being awarded the humanitarian award for AANS is like a Nobel Prize in research, in my opinion. Because I'm given nominations, I've written nominations for certain people who have not got, right? So Gail has been honored with that. She's been very active with the WANS, with the CNS, and the World Federation of Surgery Society. Gail went to med school at George Washington University, where she's been brought back as the neurosurgery clinical professor, as well as she's also joint faculty global neurosurgery at BNI, which you all know about BNI Pakistan, but real BNI, or there is Barrow Neurological Institute, where I got this introduction to Dr. Spencer, and where she has been brought back as global neurosurgery professor. She's interacting with that part of the world and with the rest of the world. She's been when I was looking at her short bio, which is also not very short, that she has been a visiting professor to 205 universities. And then outstanding. And then she over 200 international publications. And she has been active in the Washington circles and leading there's a committee of AANS which is dealt with, and the international IOC committee as well with FIANS. So there's so much I think awards which she has led, as well as so with this, Gail, we are very honored to have you. You still have one more day. I think Richard and Terry, they'll be leaving tomorrow, but we will try our best to make use of your thoughts. Thank you.
Very much. Wonderful AV team we have too. Thank you very much. Wow. Thank you all. What a nice introduction. My mother could not have done a better job. Thank you. She might not have believed all of it, but thank you. As Richard said, we are really going to be leaving Pakistan as ambassadors for the generosity and brilliance of the Pakistani people. It is absolutely heartwarming to spend time with all of you. The level of knowledge, the level of initiative, the intensity of work product, and the quality of the work product is second to none in the world. And I can say that because I've had the good fortune of traveling a lot. So I will be returning to Washington, D.C. with a message of friendship with the Pakistani people and a great sense of hope for the way you will be helping lead our profession in the future. And thank you too for allowing me to talk about one of my favorite topics here. So it was really a pleasure to put this together for you. I understand that there's a lot of microvascular decompression surgery done at this institute and others in Lahore, and I welcome the opportunity to share our thoughts about this. And once again, thank you for your kind invitation and warm welcome. So I thought in putting this together for you all today that I would do an update on my thoughts about trigeminal neuralgia this year and what the past, present, and the future are for what I think is a great operation. So let's just start by defining what we're talking about when we're talking about the definition of trigeminal neuralgia, because unlike tumors, which we just heard an eloquent talk about, we need to define this condition in a way that we all understand, because unlike tumors, we can't show pre-op and post-op films and say the tumor was here and now it's gone. Pain, of course, is a very subjective thing, right? So we need to try to put some objective parameters about it in order to be able to measure our outcomes and discuss what works, what doesn't, and where to drive our innovations in the field. So one of the early ways of designing or defining this was from international classifications, but I think our team at BNI came up with the pain intensity scale that you see there on your right, and this has become the BNI score for trigeminal neuralgia has become the accepted global criteria. So this talk is divided into these three sections. We'll first talk about the past, and of course, trigeminal neuralgia has been with us for centuries. It's been a scourge of humanity, this sudden lancinating pain. No one knows where it comes from, least of all the patient, and there appears to be almost nothing one can do until that terrible pain that came out of the blue just goes away on its own. So for this reason, it's been the focus of pioneers in surgery and progress in the treatment of trigeminal neuralgia has paralleled the innovations and progress in neurosurgery itself. I'm going to talk a little bit about Peter Janetta in just a moment. This operation is called the Janetta procedure for a reason. It was his astute microsurgical observation, bold action, and systemic documentation about the condition that has led to the large amount of knowledge we have about this condition. But also because it's a global phenomenon, there have been important contributions from many neurosurgeons from around the globe. I've mentioned just a few in the United States, Kim Burchill, and France, Mark Sandu, and certainly stereotactic radiosurgery has added a large minimally invasive, really non-invasive component to our care. But there have been particular contributions from the Asia and Pacific regions that are worth noting. Hemifacial spasm in particular seems to happen more often in Asia, and some of the most expert surgeons in this area come from your part of the world, not mine. So much so that the leading conferences about innovations and exploration in this condition tend to be in the Pacific Rim area, first in Shanghai and most recently in Vancouver, Canada. Well, in a room like this, that's named after the father of the executive director, where we have on the walls all the leading pioneers in Pakistani neurosurgery, please allow me to take just one slide to talk about the one person whose name is equated with this condition and with its best treatment. And that is Peter Janetta, who was my mentor. I was his fellow and learned so much about this condition and about life from this great man. So for those who are young people in the audience, you may be interested to hear some of the very surprising things about the early era of Dr. Janetta's contributions. So as a neurosurgery resident, he was teaching dental students anatomy and using the microscope to teach the anatomy of the head and neck. And because he was using the microscope, which was not used in surgery at that time, but he was using it for teaching anatomy, he started to notice a number of patients who had this microvascular cross conflict. Where a blood vessel was causing compression, at least touching in cadavers, the root entry zone of the trigeminal nerve. So he proposed that perhaps sparing the portia intermedia of that nerve would prevent facial numbness that was really a necessary part of the operations that his elders had proposed. He then, under the microscope, once it was used in the operating room, observed the pulsatile compression of the superior cerebellar artery and thought, aha, perhaps decompressing the nerve could be a cure. Around the same time he was thinking about that, he started seeing patients with facial spasm in the clinic and thought perhaps they are having the same kind of pulsatile conflict on the nerve, different nerve, and that decompression of the seventh nerve might be a treatment for that. Well, this eager young resident proposed an operation using the operating microscope at the time he was at UCLA, and his seniors forbid the procedure. So what did he do when they were all away at a big meeting like this? He found a collaborator who was a senior who was still in town, and he did the first operation at a peripheral hospital associated with UCLA, and it was successful. And from that came the ability to introduce it at UCLA in 1968, and he was off and running. But there were decades of skepticism about this. It was not accepted right away. In fact, there's still questions about it, but he persevered, he refined his technique, and most importantly, he kept very careful records, and they were independently logged by others so that there was no conflict of interest. And he accumulated a lot of observations that are at the scientific core of what we do. Well, sadly, he left us in 2016, having made one of the major discoveries of neurosurgery the last 100 years, and that was as a resident. He performed over 6,000 microvascular decompressions himself. So it was a major contribution to medicine, but let me also say he was a lover of the arts. He loved to play squash, he loved to play the banjo, and he was a generous, a good man, as are the leaders here. And I think it's entirely appropriate that we learn not only our craft, but also how to follow a well-lived life path from our seniors. This is all written up by my friend Anthony Kaufman and JNS. So what can we say about the approaches to the MVD? Well, this is a slide courtesy of Mark Sandu that looks at the areas of cross conflict, and it really shows that it's important to do a complete exploration when doing this operation from the brainstem all the way up to the porus of Meckel's cave, because almost 40% of patients will have multiple sites of compression, and there are sites of compression way past the central myelin area, so out in the intermediate part of the cistern and even into Meckel's cave. These areas need to be explored in order to have good outcomes. So what we love about this operation is that it's a brief anesthetic. It's a short hospital stay. You can see that the craniotomy is only about one inch long, or a little over 2 centimeters. So whether you use an endoscope or do a small craniotomy, I think probably doesn't matter. It's just a pleasure of an operation to do. Those are more of Dr. Sandhu's statistics. What we have found is that, and this is from our work, the pontine vein is very often the culprit here. So in Janetta's earliest observations, of course, it was the superior cerebellar artery, but we've learned now over time and with multiple people working in this area that it can be veins as well as arteries. It can be multiple vessels, and it can be a combination of arteries and veins. And in fact, almost 40% of the time, it is just that. So that brings us up to the present. How are we delivering good quality services to our patients who have this terrible condition, both here in Lahore and back home where I'm from in Washington, D.C.? Well, we know that we have improvement in pre-op identification of vascular conflicts on imaging, and I'll show some examples of that. It is an elegant surgical procedure with a predicted surgical anatomy. So for those who are just starting their career in microsurgery in the posterior fossa, it's one of the best ways to get started because of the predictable anatomy that one has in that CP angle region. It's minimally invasive, as I said, with or without the endoscope. Electrophysiologists who work on our teams have really facilitated the safety and the efficacy of this operation so that we get not only anatomic feedback, but we also get electrophysiologic feedback that helps us do a better job for our patients. Because as you'll see, the first operation should be the most complete operation, if at all possible. As I said, short hospital stay, rapid return to work, and it's such a gratifying and happy area of neurosurgery where patients are healthy and they generally have a permanent treatment and go back to work. The improved imaging, here's an example of our work in looking at T1 and T2, the T2 with high resolution, T1 using GAD for time of flight angio is now allowing us to actually be able to see the precise area where that vessel or vessels are in contact with the nerve. And as we noted, the transverse pontine vein alone can be a source of trigeminal neuralgia. It's an elegant technique. One doesn't even need to use a retractor in most cases. If you place the incision right and the craniotomy right, you very seldom will even need, particularly in the elderly, to use a retractor. The anatomy is very predictable, as you can see, aspirate CSF until the vascular conflict starts to come into view. And then it's a process of following our example of Yasser-Gil, doing sharp dissection of the arachnoidal planes and cisterns until we see something like what you see there with the arrow, a big vessel that is compressing the nerve. So it's minimally invasive. We use Teflon felt, but I'll get to that toward the end. You can see there's no retractors in place, and it's a very satisfying operation to do. We always make sure that electrophysiology is still intact when we're doing our final irrigation in order to be certain that our irrigant hasn't become too cold and cause problems with the nerve. So then I'd like to do a literature review for you of just the last 3 years, some of the things that are inspiring me to think further and go farther with the technique that after all has been with us since 1968. So a little literature review done especially for pins. So just from the last couple of years. So the first thing to start with is a bibliometric analysis of who's doing the articles that are having the most impact on the field. So we looked at this way back to even the pre-Genetta era. Lots of citations, as many as 38 a year. Neurosurgery happens to be the one where they're most frequent. 14 countries are contributing to our understanding here. And as you might expect, the big names through over all of that period of time are Genetta, his electrophysiologist, Muller, and then next in line is Mark Sandu, who is still with us, still practicing and still contributing to this field. If you look at some of the global trends, we're all about global trends now, the hot spots in all that we think and do, including trigeminal neuralgia research. You look at a bibliometric analysis there that is much more recent. Okay, looking just at that 3-year period from 2017 to 2020, the top centers now are in Shanghai, still Pittsburgh, and at the Mayo Clinic. But look at the names of the top authors, who are producing the most. I can't even pronounce their names. I'm familiar with their work. They're making major contributions. And this is what's exciting about this phase of neurosurgical and in fact medical research is that we are in a global world, and those who are doing the best quality work that are being published or being cited, whether you've seen them operate or even can pronounce their name or not. Now, what can we learn about some clinical aspects of neurosurgery from a review of the literature? And this was a paper looking back at 165 patients. What are the lessons learned in microvascular decompression in this European group that has a fairly high volume? And they were able to report 0% mortality. Almost never happens in surgery with 8% complications. And the important thing, as you'll see, is that even in the elderly, we see very few complications with this cranial procedure. And that's important because those tend to be, those patients and elderly patient groups tend to be overrepresented in our patient population. We found that although, as I've just shown, we can increasingly see the site of vascular cross conflict on imaging. One doesn't need to be able to see it in order to do an effective operation. It's the intraoperative exploration that's so important, and so it rewards good surgery and astute observation at surgery. In case of recurrence in this author's hands, 80% had long-term relief. If we look at venous, I've been very interested in the venous compression or the venous pulsation that can cause this problem. This is a retrospective review of 346 cases in which the main superior petrosal vein was sacrificed in 10 cases. This is not something that we normally do. In fact, we recommend not to do it, and there certainly are many published cases of venous infarction as a result of it. But if one is able, with these advanced imaging techniques, to see a transverse pontine vein, it turns out that that often provides good collateral. So if necessary, the SPV can be sacrificed if you've been able, with the big caveat that if you've been able to see and maintain the transverse pontine vein. Well, what about repeat MVD? So I've said, it's always best to get the job done first, right, completely and permanently. But when it doesn't happen, and there have been a number of series, this is a review up until 2020 of those patients who did have recurrent pain. And what they found was that on average, those who initially had good results for about 2.5 years, and then the pain returned. And those patients who underwent a second operation, over 90% were found to have effectiveness with a repeat MVD. Okay, and it was of course better if you could find an obvious neurovascular conflict, but they do have more facial numbness. So this is why we say if you can do a complete and permanent job the first time, they're less likely to have permanent numbness. Now, what about those elderly patients, which are a large percentage of our population? Well, it turns out that when one is elderly, one is more likely to have prolongation with pulsatility over time of blood vessels that actually get longer. They're dolichoectatic, so that there's an increasing number of case reports of patients who come to our attention because of trigeminal neuralgia, but then also develop hemifacial spasm. So the lesson, at least from these authors, is that there may be in these elongated dolichoectatic vessels multiple nerves that are affected, as well as multiple points along the trigeminal nerve. And so this article calls for exploring the seventh nerve as well. Have to do it safely, of course. What about endoscopic? Lots of small series. This is just one example of using the endoscope because the craniotomy that we use is so small. Many authors have said, why not just do this through an endoscope? This is an example of a typical small series. A number of them have been published now. All of these patients were BNI grade 5 preoperatively, and they found that using the endoscope at latest follow-up, nearly 90% of their patients were pain-free. They had an 8% complication rate, but 4% hearing loss. And that's quite a bit higher than it is with a craniotomy. So that's something to think about if you're considering switching over techniques. And they also have a higher incidence of delayed facial weakness compared with craniotomy. Well, other techniques that are starting to be reported, this one is using a glue, a cyanoactive glue and a sling in order to try to prevent recurrences. There are multiple small series of this technique as well. There are fewer no reported complications. One thing that you might want to consider. How about treatment strategies for intraneural vessels? This is with the problem when one doesn't see any external signs of compression, or one has completed the external decompression, then we generally do a gentle intraneural dissection to look for intraneural vessels. And in this report that looked at 5 years of in 302 cases that they had explored in that way, and nearly 20% of them had intraneural offending vessels. And that these are their recommendations for how they handled it. In some cases, they could use shredded Teflon felt. Obviously, it's very small. These are intraneural decompressions. And otherwise, sometimes the vessels were so small, the operators opted for sacrifice. Other times they wrapped them. And they found that, as you would expect, there were some cases of recurrent pain, but also elevated numbers of hemifacial numbness. This meta-analysis of patients who were elderly, this sort of sums up the experience with people who are 70 years old and above. This is a meta-analysis of 12 studies in the elderly. And what was found is that post-operatively, they do just as well as the younger cohort of patients. The long-term results are actually better in the elderly. So their conclusion is that advanced age is not a contraindication to MVD. And we certainly have felt quite comfortable operating on the healthy 80-year-old patient. And then finally, what happens when you're in a system or in a situation where patients come in extremis? We can't get them to the operating room. Narcotics generally don't work. This is one team's recommendation for how they effectively dealt with managing pain with intravenous phenytoin while waiting to be able to go to the OR. And that certainly, I imagine, could happen in a place where you have as much trauma as you do. You want to do your beautiful elegant MVD, but you might have to wait a few days because of traumas. Here's one suggested way of handling them, even in elderly patients. We've had some fun working with different databases in order to fuse data and find increasingly better ways to be able to see what we're doing before we get into the operating room, to rely less and less on intraoperative exploration. And in this, we found that time of flight 3D MRI merged or fused onto 3D CIS images was a powerful tool in helping with our surgical planning. And then finally, anyone who's done enough of these operations has had the distressing experience of having an MVD that goes very well. The patient has no pain, and then a few days or a couple of weeks after surgery, they come back with a herpes simplex or a shingles exacerbation that has broken out on their face. And so and this of course is because we believe that the herpes simplex virus lives in the Gasserian ganglion. It's opined that there's something about manipulating the nerve in its cisternal segment that reactivates that virus. In any case, these authors looked at 33 patients retrospectively in their large series who would have this all operated by a single surgeon. And what they found in looking at this is that to have a clinically apparent herpes simplex virus infection post-op or shingles on the face post-op is correlated with longer operative times. And also in their shop, they were doing HSV1 antigen studies to look at what the titers were before surgery. And if you had a lower titer preoperatively, you'd have less protection from reactivation. And those are the patients who are more likely to develop that kind of clinical scenario post-op. So as I conclude, when we think about the future, I think we'll have a better understanding of gender differences. This is something that is being actively looked at now. We want to understand why is it that this condition that's been present for literally millennia, why does it seem to affect women twice as often as it does men? We want to understand the genetic predisposition, which there seems to be. We want to understand the basic pathophysiology. Is it a demyelination injury? Is it a type of inflammation? What is it? So there are some recent studies that look at cerebrospinal fluid markers to try to help us understand what this condition is really about so that we can fine tune our treatment for it. And appears that there's a peripheral demyelinating injury and one can measure the plaque11A. That may be an interesting marker for us to look at. Seems to be that there are differences in neuronal cell deaths associated with this condition, as well as disturbances in the normal clearance of myelin to the CSF in these patients. I think it's true that anyone who does skull-based neurosurgery has seen multiple cases of CP angle tumors where you get in to remove the tumor is there, needs to be removed. The patient has either trigeminal neuralgia or hemifacial spasm or both. What do you do in these situations, and what does it mean if there's not a vessel that seems to be compressing the nerve, but it's a tumor? And so we're grappling with what that means. But I think that a greater understanding of this phenomenon will be perhaps explained by this article, which is in press. You may recognize the names of the junior author and the senior author, our own Ashraf family. I didn't know they were working on this. I just learned about it this week. This is in press and soon to be published in Journal of Neurosurgery. But they looked at the long-term outcome of microvascular decompression for typical trigeminal neuralgia using muscle, which of course Janetta was not in favor of. He thought there was something about the pillow-like consistency of shredded Teflon that absorbed pulsation, and therefore he much preferred shredded Teflon as the vehicle to prevent to treat the microvascular cross conflict. But one can't argue with over 1,000 cases where muscle really worked. And I don't doubt that the results are correct. And I think the previous slide that showed that tumors can do this certainly adds credence to the fact that a static and solid entity that is used as the implant, such as autologous muscle, which is of course available from the operative field and free, works very well. And so I congratulate you on this really important addition to the literature. And as someone who believes deeply in providing good quality and equivalent quality neurosurgical care to everyone everywhere, I'm very glad to have learned from your recent work that we don't need to have Teflon to do this operation. So in conclusion, I'm delighted to report that in 2024, I think MVD for trigeminal neuralgia is still a great operation. And I'm doubly happy to report that Pakistan is contributing to that sense, to the literature, and to the advances in this field. With that, thank you very much for your attention.
Ready? Yeah,
Now we will having a quick shield distribution. First of all, I would like to invite Professor Nazir Ahmed give shield to Professor Richard.
So before we do that, wonderful talk, Gail. And any questions? किसी को सवाल है जो पूछना चाहें before we do the shields.
So
and really was not possible here
सारी व्हीकल फोटो मार देंगे असाइनमेंट अब रखा है डिस्ट्रीब्यूशन में भी ना तरीके ना मीटिंग करने करता ना मीटिंग वो लास्ट
there was the same condition name as the phantom day. The 2 or 3 plus station. That is horizontal. That's why we get that. Just received the patient yesterday who was a plated 40 years old. But project neurology. Subtle. Now he came for another subject, but he's been. We started doing decompression of the receiving ganglion center. We expose the receiving ganglion. And that was